Psoriasis is now considered to be a genetically determined inflammatory systemic autoimmune disease. It is characterized by plaques of diseased skin often at sites of minor trauma, elbows/knees, which occur next to areas of clear, normal skin. Plaques of psoriasis are clinically well demarcated and are erythematous, dilated dermal blood vessels, with white surface scale, rapid keratinocyte proliferation. Psoriasis not only affects the skin but can also lead to seronegative arthritis in approximately 8 to 30% of patients. However, there is an increasing body of evidence that psoriasis is also associated with other important comorbidities such as type 2 diabetes, 1.4-fold increased risk, cardiovascular disease, metabolic syndrome, obesity, depression and reduced quality of life. The pathogenesis of psoriasis is complex. Nonetheless, it is largely accepted that the disease is mediated by the dysregulation of T helper lymphocytes, Th1/Th17. The development of psoriasis is multifactorial, with multiple potential susceptibility factors in a genetically at-risk individual. This combination of susceptibility factors and genetic predisposition results in an interactive web of immune cells/chemical cytokines impacting on skin cells and leading to disease. Increased understanding of these complex cellular changes has led to the introduction of multiple targeted biological therapies that are now used to manage severe psoriasis and psoriatic arthritis, PA. Globally 1 to 2% of the population is affected by psoriasis, 125 million people in UK, USA, Japan alone. A child who has one parent with psoriasis has a 1 in 4 chance of developing the disease. If one identical twin has psoriasis, there is a 70% chance that the other will also be affected. However, only a 20% chance exists in dizygotic twins. Linkage and genome-wide association studies have started identifying some of the important susceptibility factors leading to the inheritance of psoriasis and psoriatic arthropathy. The first and arguably one of the most important psoriasis susceptibility loci identified is the so-called SORS1 found on chromosome 6p21.3. This region of the chromosome contains several genes which may be important in the inheritance of psoriasis, including HLA-C, human leukocyte antigen C, CCHCR1, coiled coil A helical rod protein 1, and CDSN, corneodesmosine. Subsequently, multiple susceptibility loci on several chromosomes have now been identified, including 1q21, 3q21, 4q, 7p, 8, 11, 16q, 17q, and 20p. Recently, a loss-of-function mutation in a gene encoding an IL-36 receptor antagonist has been shown to be associated with the development of palmoplantar pustular psoriasis. Plaques of psoriasis are highly infiltrated with CD3+ T cells and seed-licked dendritic cells which produce pro-inflammatory cytokines including tumor necrosis factor alpha, NFQ, interferon gamma, INFY, and interleukin-17, IL-17, IL-22/23/12/1 which activate keratinocytes and other skin cells. Keratinocytes are the skin cells that predominate in the epidermis. They grow from the basal layer and slowly migrate to the surface. In normal skin, this process of cell turnover takes about 23 days, however, in psoriasis cell turnover is rapidly accelerated, taking only 3 to 5 days for cells to reach the surface and accumulate in large numbers, hyperkeratosis. Keratinocytes normally lose their nuclei as they move to the skin surface, however, in psoriasis they move so quickly that the cells retain their nuclei throughout the epidermis, seen as parakeratosis histologically. This rapid turnover and failure of proper maturation result in defective keratinocytes, which are poorly adherent and easily scraped off, Auspitz sign, revealing underlying dilated blood vessels. In addition, inflammatory polymorphs infiltrating the epidermis lead to swelling, edema, inflammation and erythema. These inflammatory cells may occur in such large numbers that they form collections of sterile pustules at the skin surface. These are most commonly seen in palmoplantar pustulosis, a variant of psoriasis affecting the palms and soles. The cellular abnormalities in the skin of patients with psoriasis can occur in the nails, and many patients will therefore have additional nail changes. December 8, 2023, 7:24 p.m. +9 23497924730, onycholysis, lifting of the nail plate off the nail bed, due to abnormal cell adhesion. This usually manifests as a white or salmon patch on the nail plate. Subungual hyperkeratosis, accumulation of chalky-looking material under the nail, due to excessive proliferation of the nail bed that can ultimately lead to onycholysis, pitting, very small depressions in the nail plate, which result from parakeratotic, nucleated, cells being lost from the nail surface. Bowes lines, transverse lines on the nail plate, due to intermittent inflammation of the nail bed leading to transient arrest in nail growth. Splinter hemorrhages, which clinically look like minute longitudinal black lines, due to leakage of blood from dilated tortuous capillaries. The main clinical features of psoriasis reflect the underlying pathological processes. Patients characteristically have the following. 1. Plaques, which are well-defined raised areas of psoriasis. These may be large or small, few or numerous and scattered over the trunk and limbs. Scaling may be very prominent, causing plaques to appear thickened with masses of adherent and shedding white scales. Scratching the surface produces a waxy appearance, the tache de bougie, literally a line of candle wax. Erythema or redness of the affected skin may be very marked, especially in the flexures. Erythema is a prominent feature in patients with erythrodermic psoriasis, who have greater than 90% of their body surface involved. Pustules are commonly seen in palmoplantar pustulosis, where deep-seated yellowish sterile pustules are often the dominant feature of this chronic condition. However, if pustules develop around the periphery of chronic plaques of psoriasis or sheets of monomorphic pustules appear more generally in the context of psoriasis, this is a sign of unstable disease, a dermatological emergency.